Diabetic foot management, Q&A. Welcome to the Everything Surgery podcast. Today we delve deep into the clinical landscape of diabetic foot management. Today, we'll be exploring 100 crucial questions and answers that every general surgery resident should know. Pause video when you hear the word answer to attempt answer. Let's begin. Pathophysiology and risk factors question. What are the three main contributors to diabetic foot ulcers? Answer. Neuropathy, ischemia, peripheral arterial disease, and impaired wound healing. Question. How does diabetic neuropathy lead to foot ulcers? Answer. Neuropathy causes loss of protective sensation, so patients don't feel trauma. This leads to unnoticed injuries that develop into ulcers. Question. What is the most common type of neuropathy in diabetes? Answer. Distal symmetric sensory-motor polyneuropathy. Question. Why are diabetics especially prone to infections? Answer. Chronic hyperglycemia impairs neutrophil function and delays healing. Neuropathy also masks early warning signs. Question. Can you briefly explain Charcot-neuroarthropathy? Answer. Charcot-neuroarthropathy is a progressive joint destruction due to neuropathy, causing fractures, dislocations, and significant foot deformity. Question. Let's talk about classifications. What is the Wagner classification for diabetic foot ulcers? Answer. Grade 0, no ulcer, high-risk foot. Grade 1, superficial ulcer. Grade 2, deep ulcer, to tendon or bone. Grade 3, deep ulcer with abscess or osteomyelitis. Grade 4, forefoot gangrene. Grade 5, whole foot gangrene. Question. What's the difference between wet and dry gangrene? Answer. Wet gangrene is infected and requires urgent debridement, while dry gangrene is mummified and may auto-amputate. Question. Which pathogens are most commonly implicated in diabetic foot infections? Answer. Staphylococcus aureus, including MRSA, Streptococcus species, and Pseudomonas in chronic wounds. Question. Why is peripheral arterial disease often more severe in diabetics? Answer. Diabetics often develop medial calcinosis, Munkeberg sclerosis, which stiffens arteries and reduces blood flow. Question. What is the mortality rate after a major amputation in diabetics? Answer. Approximately 50% at 3 years, mainly due to cardiovascular disease. Diagnosis and evaluation. Question. What is the purpose of the 10-gram monofilament test? Answer. It assesses loss of protective sensation in diabetic neuropathy. Question. How is osteomyelitis diagnosed in a diabetic foot ulcer? Answer. The probe-to-bone test. High specificity if positive. MRI is the gold standard, and bone biopsy is the definitive diagnosis. Question. What are clear signs of infection in a diabetic foot ulcer? Answer. Purulent discharge, erythema, warmth, edema, foul odor, and systemic signs like fever or leukocytosis. Question. Explain the role of the ankle brachial index in diabetic foot evaluation. Answer. It assesses peripheral arterial disease but may give falsely elevated results due to medial calcinosis. The toe brachial index is often more reliable. Question. When should Charcot foot be suspected? Answer. In a neuropathic patient with a warm, swollen, and red foot without an open wound, often mistaken for cellulitis or gout. Question. What imaging is best for diagnosing Charcot foot? Answer. X-rays show early dislocation or fractures and late rocker bottom deformities. MRI detects early bone edema. Question. Which lab tests are important for evaluating diabetic foot infections? Answer. CBC for leukocytosis, ESR-CRP for inflammation, and blood cultures in case of systemic infection. Question. Please outline the IDSA, Infectious Diseases Society of America classification of diabetic foot infections. Guest. Mild, superficial, no systemic signs, moderate, deeper or spreading infection, severe, systemic signs like fever or sepsis. Question. What is the role of bone scans in osteomyelitis? Answer. Triple-phase bone scans are sensitive but nonspecific. WBC-labeled scans offer better specificity. Question. How do neuropathic ulcers differ from ischemic ulcers? Answer. Neuropathic ulcers are painless with punched-out, calloused edges and good pulses. Ischemic ulcers are painful, pale, have necrotic edges, and absent pulses. Medical management. Question. What is the first step in managing a diabetic foot ulcer? Answer. Offloading the affected area using a total contact cast or walker boot. Question. What antibiotics are preferred for mild diabetic foot infections? Answer. Cephalexin, amoxicillin clavulanate, and clindamycin. covering staph and strep. Question. What about severe infections involving MRSA or Pseudomonas? Answer. Vancomycin combined with piperacillin tazobactam or meropenem. Question. Why is tight glycemic control crucial in diabetic foot ulcer management? Answer. It promotes wound healing and reduces infection risk. The target HbA1c should be under 7 to 8%. Question. Can you discuss adjunctive therapies like hyperbaric oxygen and maggot therapy? Answer. Hyperbaric oxygen therapy is useful for refractory ulcers. Maggot therapy helps debride necrotic tissue and reduce infection in select cases. Question. When is skin grafting considered? Answer. For clean, granulating wounds after debridement and infection control. Question. What's the role of negative pressure wound therapy? Answer. It encourages granulation tissue formation in large, clean wounds. Question. How does smoking affect outcomes? Answer. Smoking worsens peripheral arterial disease, delays healing, and raises amputation risk. Question. What medications improve microcirculation in peripheral arterial disease? Answer. Pentoxifylline and cilostazol are used as adjuncts to revascularization. Surgical management. Question. When is surgical debridement indicated? Answer. For necrotic tissue, abscesses, or osteomyelitis. Question. What are the common amputations for forefoot gangrene? Answer. Transmetatarsal or ray amputations. Question. When is below knee amputation needed? Answer. For a non-salvageable foot, extensive gangrene, severe infection, or failed revascularization. Question. What is the role of revascularization? Answer. Endovascular or surgical bypass improves perfusion in peripheral arterial disease to help healing. Question. How is Charcot foot surgically managed? Answer. Through exostectomy, arthrodesis, or reconstructive procedures for severe deformity. Question. What is a guillotine amputation? Answer. An emergency amputation for severe infection, later followed by definitive closure. Question. When should Achilles tendon lengthening be considered? Answer. In cases of equinus deformity causing recurrent forefoot ulcers. Question. What is a cyme amputation? Answer. Ankle disarticulation with heel pad preservation, suitable for select cases as an alternative to below-knee amputation. Question. How can reulceration after amputation be prevented? Answer. Proper offloading and custom footwear are essential. Question. One more time. What's the mortality rate after major amputation in diabetic patients? Answer. About 50% at 3 years, often from cardiovascular complications. Complications and prevention. Question. What's the most common complication of diabetic foot ulcers? Answer. Infection, which may progress to osteomyelitis or sepsis. Question. What is the 5-year survival rate after a diabetic foot ulcer? Answer. Approximately 50%, which is worse than many forms of cancer. Question. How frequently should diabetic patients undergo foot exams? Answer. Annually if no neuropathy, every 3 to 6 months for high-risk individuals. Question. What footwear is recommended? Answer. Custom orthotics, shoes with a wide toe box, and absolutely no barefoot walking. Question. Describe the podiatrist's role in diabetic foot care. Answer. Regular debridement, nail care, and ensuring pressure offloading. Question. What often causes recurrent ulcers? Answer. Inadequate offloading and poor footwear choices. Question. Is there a role for prophylactic surgery in Charcot foot? Answer. Yes. Procedures like arthrodesis or exostectomy can help prevent deformity-related ulcers. Question. What's the most common site for diabetic foot ulcers? Answer. The plantar surface beneath the metatarsal heads. Pressure points. Question. What predicts healing in diabetic foot ulcers? Answer. Adequate perfusion, measured by ABI, 0.5 or toe pressure, 30 mmHg. Question. Do bioengineered skin substitutes play a role? Answer. They are used for non-healing ulcers after debridement, such as Apligraf or Dermagraft. Advanced wound care and adjunctive therapies. Question. Are growth factors useful in diabetic foot ulcers? Answer. Recombinant platelet-derived growth factor, Bicaplermin, can stimulate healing but has limited use due to cost and mixed efficacy. Question. When are IV antibiotics preferred over oral? Answer. For severe infections, osteomyelitis, or when oral antibiotics fail. Question. Contrast superficial and deep debridement. Guest. Superficial, removal of necrotic tissue or slough by sharp, enzymatic, or autolytic methods. Deep, excision of infected bone or tendon. requiring surgical intervention. Question: how does renal failure impact diabetic foot outcomes? Answer: it worsens peripheral arterial disease, delays healing, and increases infection and amputation risk. Question: what is the role of toe amputations in diabetic foot ulcers? Answer: indicated for localized gangrene or infection. Re-amputation if the metatarsal is involved. Question: which organisms are most common in diabetic foot osteomyelitis? Answer: Staphylococcus aureus, including MRSA, Streptococcus, and gram-negatives like Pseudomonas. Question: how is Doppler ultrasound used? Answer: it assesses arterial flow and venous insufficiency, though less accurate than angiography. Question: when should a vascular surgery consult be requested? Answer: for non-healing ulcers with peripheral arterial disease ABI 0.9, gangrene, or rest pain. Question: what's the value of statins in diabetic foot care? Answer: they improve endothelial function, reduce cardiovascular risk, and may enhance wound healing. Question: what about aspirin or clopidogrel? Answer: these antiplatelet agents lower cardiovascular risk but do not directly improve ulcer healing. Surgical techniques and flaps. Question: what radiographic findings are seen in Charcot foot? Answer: midfoot collapse, rocker bottom deformity, and Lisfranc fractures or dislocations. Question: how long should antibiotics be given for osteomyelitis? Answer: typically 4 to 6 weeks intravenous or oral after surgical debridement. Lifelong suppression is considered for unresectable cases. Question: what does pulse lavage contribute to wound care? Answer: it uses high-pressure irrigation to reduce bacterial load as an adjunct to debridement. Question: please explain the role of maggot therapy. Answer: maggots debride necrotic tissue and disinfect wounds via proteolytic enzyme secretion. Question: what's the purpose of silver dressings? Answer: they have antimicrobial properties to reduce bioburden in infected or colonized wounds. Question: are honey-based dressings used? Answer: yes. Their osmotic effect debride slough and manuka honey has antibacterial activity. Question: what about collagen dressings? Answer: they promote granulation by mimicking the extracellular matrix. Question: do amniotic membrane grafts have a place in treatment? Answer: they provide growth factors and scaffolding for chronic wounds. Question: what about electrical stimulation? Answer: it may enhance angiogenesis and epithelialization in refractory ulcers. Question: is platelet-rich plasma helpful? Answer: it offers concentrated growth factors from autologous blood, but evidence is limited for diabetic foot ulcers. Revascularization and amputation techniques. Question: are autologous skin grafts used? Answer: split-thickness grafts are preferred for large, clean ulcers. Avoid in infected or ischemic wounds. Question: what about allografts or xenografts? Answer: they offer temporary coverage while preparing the wound bed. Question: which to choose, surgical or endovascular revascularization? Guessed: endovascular, best for focal lesions. Angioplasty stenting, surgical bypass, ideal for long segment occlusions like femoropopliteal disease. Question: is there a role for cryotherapy or laser therapy? Answer: cryotherapy is limited to recalcitrant hypergranulation. Laser therapy has weak evidence for wound healing. Flap reconstruction and amputation refinements. Question: what is ultrasound debridement? Answer: a low-frequency technique that loosens necrotic tissue. Question: what about enzymatic debridement? Answer: collagenase breaks down necrotic tissue, though it's slower than sharp debridement. Question: what is sharp debridement? Answer: the gold standard for rapid removal of necrotic or infected tissue. Question: can you discuss hydrosurgery? Answer: hydrosurgery uses a high-pressure saline stream for selective tissue debridement. Question: what is incisional negative pressure therapy? Answer: applying negative pressure wound therapy over closed incisions to reduce dehiscence after amputation. Question: when are split thickness versus full thickness grafts chosen? Answer: split thickness covers large areas but is fragile. Full thickness offers better durability for plantar defects. Question: are free flaps used in diabetic foot ulcers? Answer: rarely, but when needed. Options include latissimus dorsi or anterolateral thigh flaps. Question: what about local or rotational flaps? Answer: local flaps like VY advancement cover small defects. Rotational flaps transfer nearby tissue to cover exposed bone or tendon. Question: muscle versus fasciocutaneous flaps. Differences? Guessed: muscle flaps, better for infected wounds, e.g., gastrocnemius, fasciocutaneous, more durable for long-term coverage, e.g., sural artery flap. Amputation-specific techniques. Question: what is the role of the sural artery flap? Answer: it covers distal tibial and heel defects, based on peroneal artery perforators. Question: and the reverse sural artery flap? Answer: used for heel and ankle defects, relying on retrograde peroneal artery flow. Question: explain the medial plantar artery flap. Answer: provides glabrous skin for weight-bearing heel reconstruction. Question: what about the lateral calcaneal artery flap? Answer: it covers lateral heel ulcers. Question: what is the cross-leg flap? Answer: historically used for large defects, rarely needed now due to advanced techniques. Question: please describe the fillet flap. Answer: it uses tissue from a non-viable foot to cover an amputation stump. Question: what is the Erdl procedure in below-knee amputation? Answer: it creates a tibiofibular synostosis for a better prosthetic fit. Question: what is targeted muscle reinnervation? Answer: it reduces phantom limb pain by connecting cut nerves to motor nerves. Question: what is ASIA integration? Answer: direct skeletal attachment of prosthetics, still experimental in diabetics. Rehabilitation and prevention. Question: what are the prosthetic needs of diabetic amputees? Answer: custom sockets for pressure redistribution, fitted after stump maturation. Question: how important is physical therapy post-amputation? Answer: it improves mobility, prevents contractures, and strengthens the limb. Question: should psychological support be offered? Answer: absolutely. It addresses the high rates of depression and anxiety in this group. Question: is there a role for palliative care? Answer: yes, for managing pain, infection, and quality of life in non-reconstructible cases. Question: when is hospice appropriate? Answer: for end-stage diabetic foot with gangrene or sepsis where curative treatment is not possible. Question: and finally, what is the single most important factor in preventing diabetic foot ulcers? Answer: multidisciplinary care with podiatry, endocrinology, vascular surgery, and above all, patient education including daily foot inspections and strict glycemic control. Thank you for joining us for this comprehensive podcast on the management of the diabetic foot. Stay tuned for more in-depth clinical discussions.